So let's talk a little bit about angle surgery. It's a nice interlude. Just some disclaimers. None of them have to do with the $5 suture or a 20 rupee suture. So I want to talk about just an overview of my surgical algorithm, kind of talk about the collector channel, talk a little bit about the wave, and then discuss some things on GAT and go from there. So, when I talk to my patients, I tell them I'm basically a fancy plumber. And your eyes like a drain in a faucet. I'm going to open the drain or create a new drain. And my goal is to first open your own drain. And if I can open your own drain with a GAT or a dual blade or an iStent or one of these things, wonderful. If I can't, or you don't have an intact collector system, then we need to create a new drain. And that's what we are learning about also with trabeculectomy and tubes. And then I'll talk a little bit about some of the Zen and InFocus tomorrow. And then you can also turn down the faucet. But the big controversy that everybody talks about, there's the joke of this isn't minimally invasive glaucoma surgery, this is minimally effective glaucoma surgery. And there's these two groups of people that just keep butting heads. And you go to these meetings and everybody's, half the audience is saying MIGS is great, the other half is saying MIGS is horrible, you guys are just doing a bunch of unnecessary surgery, they just need to do a trab. And I think the answer is when a patient has an intact collector system, MIGS is effective. When a patient does not have an intact collector system, then it's MIGS. It's minimally effective. The question is, how do we know? So this is from Nesterov from 1978, India Inc. Studies of the Schlemm's canal, aqueous veins, and the collector channels in a patient with normal glaucoma. This is advanced glaucoma. This patient has no intact Schlemm's canal, has an atrophic collector system. I don't care what you put in the angle, it's not going to work because you're shunting to nothing. This patient needs a new drainage system. So this herein answers the question of who is MIGS effective with and who is MEGS. This patient needs a new drain. So before you do any angle surgery, you need to understand the angle. You need to understand there are about 25 to 35 collector channels, and then you have these large aqueous veins, which I think I was able to show on during the wave of one of that surgeons. I'm not sure if it came through. But if you were an aqueous molecule, how do you leave the eye? There's two pathways. You have these large aqueous or Asher veins, and then you have the plexus. You go through the collector channel, you go through a deep, mid, and superficial episcleral venous episcleral plexus. And is there a way to clinically assess a patient's inherent collector system? And I think there is, yes. So this is after a GAT you guys just saw. And let's see what's going to play. There we go. Okay, so look up here. Again, the most important angle is the nasal angle. You're going to see all this little plexus, and then you're going to see some of these deep veins. And watch this vein. I believe it's this one right here. Can you guys see that? It's going to be like this one right here in the nasal quadrant. As I pump up the eye, and again, as I kind of discussed during the surgery, you see this plexus right here, and then you're going to see this one go away too. But the more you flush the system with balanced salt solution, it's a lavage, and almost like you're popping up collector channels, or you're pushing through all this gunk, and you're getting a better view of the capacity for outflow. And here's an example of a patient with an amazing wave after surgery, pumping the pressure up to about 30 or 40, and you see complete blanching. It's not blanching; those aqueous vessels are diluted with balanced salt solution. And so, Dr. Feldman, one of my partner in crime, he came down from the operating room one day, and again, he's the one that kind of observed this, and he's like, "You guys would never believe what I just saw." And we described it in 2012 in patients with the trabectome, but you can see, basically, this is not Photoshop. This is really, you see this blood reflux, and then you irrigate it, and the vessel is blanched because it's full of balanced salt solution. And you see that this is an aqueous vein, and then this is the plexus that disappears. And the question is, does the presence or quality of this wave correlate with outcomes? And so what we did was I didn't want to do this with GAT because no one knows what the heck GAT is. So we tried to pick a more established surgery that people were familiar with, at least in the US, and we used trabectome. And the question was this, do these patients do differently? A patient that has this diffuse wave versus a patient that has a limited wave. This is before and this is after. Do these patients differ? And we published our results in ophthalmology back in 2015. we did a retrospective study of 68 eyes, 49 patients. And we didn't really want to do, okay, what was the IOP lowering? We just basically wanted to know what the IOP was before or after. We weren't looking for a percentage or success or failure criteria. And the only failure we said was, okay, a patient failed if they needed a different additional surgery. Did they need a new drain? So what do we find? So the baseline IOP in this group was 19.3 on 2.7 meds. The extensive wave group went down at 12 months to 13 meds on 1.4, 13 millimeters of mercury on 1.4 meds. The poor wave group didn't change at all. They were 18.4 on 2.9 meds. It's basically the same as the pre-op group. So right here we have MIGS versus MEGS, right here based on what we saw intraoperatively. And when we look at failures, how did patients fail? So 5 of the 68 eyes needed further surgery. 4 of those 5 patients were in the bad way, the ones that had no wave at all. So 4 out of 11 patients that had no wave needed surgery, about a third of patients. So I use this when I talk to my patients afterwards and before the surgery. My patients during the surgery will ask me, Dr. Grover, did you see the wave? Did you see the wave? And I'm like, please don't talk. I'll tell you later. But I let them know that if I see a wave, and they can go on YouTube and see the videos, you give them ownership, and that allows you to they maintain confidence in you if the surgery doesn't fail, because they understand what we're battling. And I tell them, hey, if I see a wave, very good chance that this is going to work. If I don't see a wave, about a 1/3 chance we're going to need a new surgery. And they get it, and you give them ownership in that knowledge, and they don't lose confidence in you if the surgery doesn't fail, because they understand what you're trying to do. So let's talk a little bit more about, so we just talked about trabeculotomy. We had a couple talks today about trabeculotomy. And we've seen an evolution of trabeculotomy in adults and in kids over the past 50 years. We know that it works well in developmental glaucoma. I think without question, 360 trabeculotomy is the gold standard for pediatric, primary congenital and juvenile open-angle glaucoma. But it's actually quite useful in primary open-angle glaucoma and pseudo-X. And these outcomes are just like TBT, so no different than trabs or tubes in this group. We also have good studies that show the more the angle you open up, the better the patient does. And in this group, the patients were able to open up 360 degrees, did a lot better than the limited trabeculotomy. But what's the problem with the ab externo technique? It takes a lot more time, requires multiple conjunctival sutures, scleral flap. You're violating the conjunctiva, which may preclude the success rate of further surgery. So then we just talked about the GATT, which is what we developed back in 2011. Here's a schematic of kind of what's done, and I'll talk you through what the ideal picture is. You know, you make your initial goniotomy. You can do this with, as you've ever seen, a catheter or a proline suture. You pass it around 360. You retrieve the distal end, and then you externalize it. And this is just what you guys saw today with the proline and the steps of the proline and kind of what's involved. But that blunting of it right there is the ideal size and shape that you want. If you make the tip too big, it won't go around the canal. And it's a 5-0 proline. 6-0 proline is not strong enough to push through, and 4-0 is too big. So after playing with it, I've tried proline, I've tried nylon, I've tried everything. The thing I found to work best is a 5-0 proline with a small blunted tip. So we initially put our technique and our results in ophthalmology in 2014, showing in POAG and in secondary glaucoma, there was a substantial and sustained drop in pressure and decrease in dependence in drops. And depending on the group, the cumulative proportion of failure at 1 year ranged anywhere from 0.1 to 0.3. We reported our results in primary congenital glaucoma and juvenile open-angle glaucoma with patients anywhere from 17 to 30 years. I've done this in 3-month-old babies. And again, a really tremendous drop in pressure. This is the gold standard. A trabeculotomy circumferential, however you do it, in my mind is the gold standard for this type of patient. So I want to talk about a little bit our short-term, mid-term results. About 200 eyes of 200 patients that had no prior IOP lowering surgery with 18 to 24-month follow-up. Let's take some time to kind of just look at this table, because this is how I'm going to present a couple of the slides. So this is the POAG group. It's not finished up. That's the POAG group. That's the group that had POAG that just had a GATT. The second column is POAG combined. That's patients that had POAG that had a phaco GATT. The third one is pseudophakic patients that had a GATT. And then the other is secondary open-angle glaucoma, isolated GATT. Other combined is secondary open-angle glaucoma that had a phaco GATT. And then other prior cataract surgery are pseudophakic secondary patients. And then if you look at I mean, this is real deal glaucoma. Even in the U.S., this is real deal glaucoma. These are patients that have pressures in the mid-20s to 30s on 2 to 3 meds with a mean deviation of anywhere from -6 to minus 12 almost. And if you look at the 24-month outcomes, in every group, we're seeing, this right here. You're seeing a sustained drop in pressure and a sustained decrease in dependence on drops across the board. Now this group, this pseudophakic POAC group, this column right here, 16 of the 37 required more surgery. So that group did a little different. We know that group behaves differently. Pseudophakics behave differently even after trabeculectomy, but that group behaved a little different. I'm going to explain why. This is a Kaplan-Meier curve of the cumulative proportion of failure broken out by all these different groups. And you can see that the secondary groups did without question better, because in most secondary patients, we know the resistance is the TM. In the primary open-angle glaucoma group, the patients that did the worst were the pseudophakic POAC groups. And let me preface all this. These are the first 200 eyes we ever did. So the minute we discovered this, we thought this was the best thing ever, and we were doing it in everybody because we were just so amazed by it. We're now learning that the big thing, as I talk about the difference between MIGS and MEGS, is who this should be done in. And you see that Kaplan-Meier curve, that curve that shoots straight up. Those are the patients that were pseudophakic GAT patients, and they failed. The vast majority of them failed because they needed more surgery. But if you look at the other groups, at 24 months, the cumulative proportion of reoperation ranged anywhere from 0.1 to 0.3. That's the same as TVT. That's the same as anything, but in this case, we're not touching the conjunctiva. But we asked ourselves, okay, well, can we predict who's going to fail? And so we don't have a way to look at the wave, or we did, but we didn't in this case. So I said, well, is there a thing we can look at? Is there a proxy for outcomes? And we broke patients down by mean deviation on visual field. So we had patients that had mean deviation of -3 or better, -3 to -15, and then worse than -15. Look at that -15 group. These are the patients that I showed you that had no collector system. 90% of them failed within the first 3 to 6 months because they had no collector system, so they needed a new drain. All the other ones did quite well. So now, when I think about patient selection, I think about stage of disease, and that's going to be the very interesting thing in this population, because the patients that have a mean deviation of -15 or -20 in our population, they've been on drops for 10 years. Their eyes have been abused by drops. But from what I understand, the vast majority of patients you guys see that have advanced glaucoma are virgin eyes that haven't been abused by drops. So I'm optimistic that even those patients in this population will do well with the GAT. And what I've seen today on all 3, or 2, and then the one I did yesterday, all 3 of those patients had a mean deviation about -10 to -15, maybe even worse. We're pretty advanced, but they intraoperatively had a very amazing outflow capacity. They all had a wave. They all had blood reflex. So I'm very optimistic that they're going to do well. Nothing is without complication. If you want to avoid complications, you don't operate. The vast majority of complications are hyphema. Leaving GV in the eye and preventing against immediate postoperative hypotony will help. You can, if you're not careful, you can get an uridialysis. This recurrent hyphema patient on month 8, that was a yoga instructor, and anytime she did yoga with her head down positioning, she'd get a recurrent hyphema. And you can, with any angle surgery, especially when you're doing trabeculotomy, you can get a limited decimase detachment. That usually resolves on its own. So in conclusion, GAT, it's a novel, safe, minimally invasive surgery. The midterm results are just as successful as the previously published results for the ab externo approach, if not better. At 12 months, the cumulative proportion of failure ranged anywhere from 0.18 to 0.48. If you exclude that weird group, that pseudophakic GAT group, they actually range anywhere from 0.18 to 0.3. The vast majority of patients did not need additional surgery. Patients that had secondary glaucoma and had combined cases, phaco-GATs, tended to do better. The POAC group, we're learning that maybe mean deviation is a proxy for the inherent outflow system and the health of the eye. The pseudophakic GAT group did poorly for a lot of reasons. They had more advanced glaucoma. They failed from needing more surgery, and we also know that just pseudophakics tend not to do as well even with trabeculectomy. So there's something about them that we don't know. In conclusion, we need longer follow-up. I think it'd be great to do a prospective GAT study. I'd love to be involved in any type of project here on expanding knowledge in GAT and doing trials. this has tremendous implications for cost-effective healthcare. No one ever talks about cost-effective MIGS, but I think this has very tremendous implications worldwide for treating glaucoma surgically without spending a huge amount of money. So, in conclusion, angle surgery I think is still important. I think it's a great way to treat it. I think there's this MIGS and MEGS debate, and the wave and mean deviation can maybe give us insight into a patient outcome. So, patients that have a great wave and intact collector system, that's MIGS. Patients that have a destroyed and atrophic collector system, that's MEGS. We're trying to find a better way to determine that preoperatively, but I think the wave is a reasonable intraoperative indicator for outflow capacity, and learning about the characteristics of the wave can make us smarter about the parts of the eye that we can't visualize. So again, this visual field issue gave us some insight into stage. There's no really, when you do a trabeculectomy, you see a bleb, it's working. With angle surgery, when a patient fails angle surgery, we don't understand why. So we don't understand wound healing in the canal and why a patient will do well with GAT and then a year, 2, 3 years later, even though they have an open shelf that we see, will fail. So we're still trying to understand wound healing in the canal and outcomes with angle surgery. So I'd like to acknowledge my colleagues without whom I couldn't do this. This is my glaucoma family and my home family. So it's just really been an honor to be here. Thank you guys. Every time I come here, I always get more than I give, and I'd love to be given more opportunities to give back and involve, and I'd really like to thank the Arvind Eye Care System. I don't know if any of you guys know, I've been here 3 times. One was even before I decided I wanted to be ophthalmology, and I think my experience and understanding the impact of what Arvind has done for the world really planted that seed and led me to want to pursue ophthalmology. So it's really an honor to be back here. I'd like to thank, Dr. Nam, Dr. Nachair, Swati, great job with planning everything. You guys really helped making this live surgery as easy as possible. And Ganesh, we've been emailing, making sure we had everything we need. So thank you, Dr. Ganesh, Dr. Krishnadas, Dr. Ram, Akash Krishnan. Thank you guys for having me. It's been a pleasure. And Alan, thank you for inviting me. I really appreciate that. So, and thank you, and Dr. Veena, thank you guys for hosting us.